doing really extensive stuff to this guy. Film and then film again and then watch.
Hello, everyone. I'm Susie Wolf. I'm one of the presenters for today's Lyceum. I am with the Physician Assistant Program, and we're going to just give a few more minutes. We've got about 5 more minutes before we get started, but we're glad to see the number of participants that we have thus far. And so we will start at noon. Okay, welcome. As I mentioned before, my name is Susie Wolf. I'm an assistant professor with the Physician Assistant Program in the Graduate Health Professions Division of Wingate University, and I'm presenting today with Dr. Laura Happy. We're so excited to be here with all of you today, and obviously talk about something that's very much so on our minds right now. So we just want to share with you some of our thoughts and analysis of various epidemiologic simulation models associated with COVID-19, the coronavirus. And it's a pleasure for us to be speaking with all of you today.
Yeah, hi guys. So I'm Laura Happy and I'm a faculty member in the School of Pharmacy. I'm a pharmacist by training and I also have a master's in public health with an emphasis in epidemiology. So like Susie said, we're really excited to chat with you guys today. As we kick this off, I wanted to do something. I like to use the chat box. We'll use the chat box in our discussion today. So I wanted to use that and do a one-word check-in with you guys. So if everybody could just turn on your chat box and just give us one word, maybe what you're thinking, what you're feeling, about today. So I'll go ahead and start. So my word is concerned, hydrochloroquine, tired, good, worried, phenomenal. Glad to see that. I love whoever's feeling phenomenal. That's great. Yeah, these are great too. Thank you. And as you're doing that and just kind of watching and taking a pulse on your colleagues, I also encourage you guys to turn on your videos. You know, one of the things we're going to be talking about today is social isolation and you know, it's a really strange time. We're disconnected from each other, and that's really, frankly, not good for our health. And so just, you know, having this social connection, using our videos, it's a totally judgment-free zone. We don't care what you're wearing, if you have makeup on or not. So go ahead and share your video if you're comfortable doing that. Yeah, and thank you guys for these words over here. I see just a range of different things, and I hope that our discussion today will kind of help you on, you know, some of these things. I'm seeing, you know, people who are excited about graduation. Gosh, I think probably a lot of people that are on today are seniors, and what a strange and weird time for you. And so we're definitely thinking about you with that. We've got emotions of feeling isolated, worried, sad, tired, people that feel good. So there's just a range. I see some words around confusion. So we're just going to share one aspect of the COVID-19 epidemic today that we're going to talk about. So hopefully we can shed some light on that. Basically what Susie and I are going to talk about today is, I'm sure you guys have all heard this phrase that's being used, flatten the curve. Right, so I bet you can kind of visualize that chart where there's the two curves. There's the steep one, and then there's the one that's more spread out. So that is actually based off of an epidemiologic simulation model, and that's what we're going to do today. So basically, we're going to kind of unpack that headline, and we're going to dig into what are the analyses that were done to come up with that projection of flattening the curve. What assumptions went into that? What were the modeling techniques? And then how do we interpret that, and where do we go from here? So that's really what we're going to spend time doing today. So with that, I'll turn it over to Susie to talk about our objectives.
So for our objectives today, we're going to be looking at some different terms as they relate to epidemiology, and we'll be really trying to define epidemic versus pandemic. Additionally, what exactly is epidemiology simulation modeling? We're also going to try and explain and compare and contrast, you know, what is suppression versus mitigation in regards to an epidemic. We're going to consider an epidemiologic simulation model specifically for COVID-19, and we're going to try and help you guys, as Dr. Happy said, really understand what that model looks like and the implications associated with it. And then, of course, the applications and limitations of the model. With every model, there's going to be limitations, and so we certainly want to be mindful of those today in our presentation.
Yeah, and as we go through this today, guys, feel free to just use the chat box to interject any questions, and we'll try to take those as we go along, and then we'll also have some time for questions at the end.
So before we get started, it's going to be super helpful if we can help you guys understand some keywords in regards to epidemiology. So in general, epidemiology is the study of distribution and determinants of disease. So when we think about distribution, we think about, for example, the spread of disease, which areas it's popping up. You can also kind of think of it as who, when, how. And then determinants is really going to be, if you want to consider it, like characteristics of the disease. So those could be things like age or gender, comorbidities, underlying health issues. But it's really going to be looking at the distribution and the determinants. Additionally, specifically when we look at, for example, with COVID-19, we're really interested in something called R. And R is the reproduction number. And so what that means is for every number of cases, how many secondary cases are going to be generated from that infected person. So to give you an example, the estimated R for COVID-19 is about 2.4. So for every case, that's estimated that 2.4 cases will result from that case. And for influenza, it's estimated to be approximately 1.3 to 1.4. And then additionally, if you look at the image here, you can see the differences between an endemic situation, epidemic, and pandemic. With COVID-19, the coronavirus, it really kind of started from, at least within the headline, something was being described as an epidemic or quote unquote outbreak. And then just recently, the World Health Organization obviously deemed it a pandemic issue that was affecting us globally. So those are some of the basic terms that we think will be helpful as we go through this presentation. So what exactly is simulation modeling? Well, we use simulation modeling for a whole wide variety of different situations. You can use modeling financially to come up with different types of financial models, and you can also use it within the healthcare field, where we're trying to basically make assumptions regarding outcomes. So simulation modeling, you can do it either very simply or you can make it very complex, and there's many different software platforms that are available to assist people in simulation modeling. And what the outcomes are, the assumptions, is really dependent on the various inputs that are being inputted into the model. But there are specific simulation models which can help with trying to gauge potential outcomes of an epidemic or pandemic situation, which is what we're going to be looking at today.
Yeah, and with any simulation modeling, the reason you do a model, the reason that you're simulating and forecasting is because there's some unknown. So you're trying to project something that you can't figure out another way. And so, as Susie said, we build these models based on inputs. So what do we know that we can use to project? And so when we interpret those models, it's really important that we understand what are those inputs and what are those assumptions that were made, so we can know what level of weight to put on the results. I'm going to ask everybody to mute your lines. Actually, I can probably mute you all. Okay, there, Susie, you may have to unmute yourself now. Okay, great. Yeah, so that should be better. So sorry about that. All right, so I was saying, so it's really important for you to understand when you interpret any sort of model, what were those assumptions that went into it, so you can understand kind of the weight in which you're going to interpret the results. And so those are some of the things we're going to go through today, and we'll circle back to that. I also just wanted to note that there's a question in the chat box. Why is R considered so critical? So R is basically the spread of disease. And, as Susie pointed out, the R value for COVID-19 is estimated to be around 2.4 in contrast to flu, which is just over 1. So the point is that it is more contagious. So one person is affecting 2.4 people instead of affecting just over 1 person. So that's kind of why it's important. And I think as Susie starts to talk more about the models, you can kind of see how that plays in.
So the model that we're focusing on today is a model that was already in existence because a group of epidemiologists associated with the Imperial College of London had created this model, and it was originally developed to support a pandemic influenza type of planning situation. And so they were able to modify this model once obviously the coronavirus became the concern that it did. And it's something that recently came out in publication. And so it's been a very important model for this particular pandemic, because it's been used to help gauge and deliver a lot of different policy recommendations and regulations, which we're now seeing in place today. So we do have a live link here if you want to click on it to actually see the greater details associated with the model. But that's the particular model we're going to be discussing today.
Yeah, and we've also put these slides in the chat box, so you should be able to download these slides if you're not able to click on the link from our presentation.
So this is what we're essentially talking about when we say flattening the curve. If you can see the image on the top right-hand corner of this particular slide, this model has been instrumental because it's really helped us understand what the different types of situations could be dependent on regulations or restrictions that are put in place to try and mitigate or suppress the COVID-19 epidemic that is occurring right now. And so what you see here in the top right hand, what we have here on this graph, you can see the red, very large surge here is going to be without measures to slow the spread of infection of COVID-19. And what's important to note here is this dotted horizontal line here. We see capacity of the healthcare system. And so that's really important. When we say flattening the curve, what we're trying to do is flatten this red curve down to this blue one here. And so with the blue curve that is much more distributed over a longer period of time, you can see that the x-axis here is days after initial outbreak. This blue curve is with measures to slow the spread of infection. And so that's going to be some of the things that we're going to talk about that you've probably heard throughout the news: social distancing, quarantine, isolation. Those are some of the things that we're going to be talking about in regards to measures which could affect the spread of the infection. And so it's important to note that with any type of simulation, it really is dependent on the group of people who are creating the simulation model and also the inputs that are being put into that particular simulation. So Dr. Deborah Birx, she is a physician who is on the White House Strategic Task Force associated for COVID-19. And this is just a quote of her saying that, you really need to be mindful of the inputs that are being put into a particular simulation model, and constructing it the best that you can for the particular region that you're trying to serve, which is obviously the United States of America. So they are looking at this model, they're looking at specific inputs and outcomes associated to best make policy decisions for the United States of America. And that's what we're really seeing come out a lot in our, obviously, media and news headlines.
Yeah, and just to add to that, so this model was released by the Imperial College on March 16th, and this transcript of the press briefing from March 17th referred very explicitly to this model. The question that Susie talked about the response to, the question from the reporter was about this model that projected 2.2 million deaths if we do nothing, which is going to be the first result of the model that we're going to walk through today. And this on March 17th was when the White House did release the president's 15-day plan for addressing coronavirus. So it's definitely been highly weighted in the policy decisions here in the US.
So there's two main strategies which we're going to be looking at with this particular simulation model, one being suppression and the other being mitigation. And it's basically a two-case scenario. So what happens if we take this approach and what happens if we take this approach? And we're going to try and really explain to you the differences between the approaches versus the inputs, the measures that are being compared, and then of course the potential outcomes. In general, suppression is the goal to reduce the reproduction number, that R number, to below 1. So remember we said that it's estimated for COVID-19 about 2.4. So it's to get that number to below 1 or to eliminate human transmission of the disease in totality if possible. So that would be a much more intensive approach to dealing with this particular epidemic. Whereas mitigation, the goal is to interrupt transmission, not to interrupt it completely, but to reduce it to the point where we don't necessarily have that huge surge that's going to be overcapacitating our healthcare system. It would be slowing it, but not necessarily stopping transmission. And so we're going to look at some of the differences and what that would look like in regards to outcomes.
Okay, so next we're going to talk through what were the actual inputs that they used to construct this model. So again, you can kind of envision if you were creating basically a mathematic model using Excel or a more advanced software system like Tableau or Triage, actually finding values for each of the numbers that you might need to model out the impact of this disease. So first they basically did two models. They did one for the US and one for the UK. So for every set of inputs, they had it for both the two different populations. So when we talked about, or when they developed the population to input in the model, they came up with, of course, the population size, and they used census data to populate that. What was the age distribution of the population in both countries, and then what is the average household size, because of course household contacts and spread of disease between household members is important here. So they used census data to come up with those inputs. Outside of the home, there's also the school population, which is going to be an important part, a place for where we have transmission. So for that, they looked at the average class size and the average student to staff ratio to simulate that school population. Next, you have the workplace. So again, they use data to support the average workplace size and the workplace locations, so they could model out commuting patterns and how people interact with one another in the workplace. And so basically they took that whole population in the US and the UK and assigned them to one of these locations to start, either the home, the workplace, or the school. And then they run simulations as people are moving about through their life and modeled out what the possible transmission of the disease would be, which is what we're going to look at next. So transmission of the disease, so what kind of inputs did they have to consider for transmission? So the first input that they used is the incubation period of the disease, so when a person is infected versus when they actually develop the disease. So the incubation period assumption is 5.1 days. They assumed that a person would be infectious, where they could spread the disease from 12 hours prior to the onset of symptoms until 4.6 days after the infection. They assumed an R value of 2.4, which we talked about a little bit earlier. They did test a range of assumptions. So 2.4, the R value is very important. So this is for every case, how many additional people, how many additional cases result from every case. So as you can imagine, this is really important, a very important input in the model. So they tested a range of values between 2 and 2.6, and we'll look at the impact of that range on the results a little bit later. For the R value, they also assumed that symptomatic individuals were more infectious, in fact, 50% more infectious than asymptomatic individuals. Next, in terms of transmission, where did they assume that occurred? And they populated these transmission numbers based on a prior model that they had created, and they collected this data from survey data, and they assumed that about 1/3 of transmission happened in the household, 1/3 happened in the community, and the remaining 1/3 happened in the combination of the school and the workplaces combined. And then lastly, they assumed that individuals who were infected were immune to reinfection. So if you had it once, you couldn't have it again. So now that all being said, I think I hope it is clear to you that these are, this is a fairly new virus, new disease. We don't know a lot about it. So these are very much assumptions. We're continuing to learn more about the disease every day. The nice thing about models like this is, if we learn that the incubation period is different, for example, they can just go into the model and adjust that number and rerun the analysis and take a new look at the results. So those are the inputs around transmission. So then ultimately, what are the outcomes of this model? So the outcomes are looking at what happens to these cases and how that relates to the demand on the healthcare system. So this is just a screenshot here of the assumptions that they made and the inputs that they made for exactly that. So you've got across the top the percent of symptomatic cases that require hospitalization. And then of those hospitalized cases, what percentage of those require critical care or ICU beds? And then what is the infection fatality ratio? In other words, what is the death rate? Of course, all of these variables are going to differ by age range. So you can see in the rows here, they've got the different age ranges. So for example, at an age of 80 plus, the assumed death rate is 9%. Whereas if you look at 30 to 39, you're talking 0.08%. So there's different inputs by the age range. It seems like we're continuing to learn more about this as well. I saw in the news last night, even in Mecklenburg County, that we have 108 cases diagnosed in Mecklenburg County, and the age range that is most affected is the 20 to 40-year-olds. So we're learning more about the disease, so these inputs are also potentially, subject to vary. Okay. So those are the inputs. Now we want to look at what are the possible interventions, and this is ultimately what we're trying to figure out is if we implement these different possible interventions, what is going to be the result on the spread of disease? What is going to be the result on the number of people that need hospitalization or ICU beds? And what is going to be the result on the number of people that die? So these are terms that you've probably heard on the news, but I'll kind of walk through these at a fairly high level. So the first one is case isolation in the home. So this means that, of course, a person that is infected and diagnosed is restrained to their home. Now, the model gets really specific, and I'm not going to go through this level of detail for each of these interventions, but let's just look at this one as an example. So this is how specific it is, that the cases stay at home for 7 days. That reduces their out-of-home or non-household contacts by 75%. But their household contacts remain unchanged. And then it also assumes that 70% of the household complies with that policy. So, there's a lot of details in here that can result in some variation of the model. So for example, in the US, for people that have the disease, they're asking them to quarantine for 14 days, so it's longer than what's assumed here. So that's case isolation in the home. The next one is voluntary home quarantine. That's the second intervention. And that refers to the household members of someone who's been infected. So I'm sure you've heard this as well. If you have a member of your household who became infected, then you should also quarantine. And so that's what this is. The next one is social distancing. And so the authors of the study looked at social distancing for people greater than 70 years of age. So that's that particular input. And then the second one would be social distancing for the entire population. So they looked at different strategies as it relates to social distancing. And then lastly, they looked at closures of schools and universities, which were acutely affected by all of us who are on the phone or on this call right now. So these are all non-pharmaceutical interventions. They're public health interventions. So this modeling exercise does assume that we don't have an effective treatment, which we don't have an effective FDA treatment as of today. It also assumes that we don't have a vaccine. So now if either of those two things were to happen, then the results would change as well. So that kind of sums up the inputs to the model. And Susie, you want to talk through the results?
Right. So now that we've talked about the inputs and some of the different aspects that will help us create a more accurate picture of potential outcomes for our assumptions as to how much of an effect the virus could have, let's look at what some of those outcomes were for this particular model. So if you look at this graph here, this is showing you the results for no mitigation strategy. So if we just left things be the way they would be naturally without any type of precautions or regulations. This is something that we might see. Now, before you look at the peak in the graph, let's try and orient ourselves to the X and Y axis. So if you look at the X axis on the bottom here, we obviously have time. So we're looking at March 2020 through October 2020. So we're able to compare the outcome of the disease based on a monthly basis. Additionally, if you look at the y-axis, we can see deaths per day per 100,000 population. So they're trying to normalize differences in population, because if you look at the total population for Great Britain, which is GB, so Great Britain is going to be England, Scotland, and Wales, it's a total of approximately 500,000. Whereas for the United States of America, we're at 2.2 million that they're looking at here. So you can see that we're seeing a much more larger effect in regards to the graph here for deaths per 100,000 population for Great Britain compared to the United States, but overall we're looking at a larger total population affected. And so we can see this is what it would look like without any type of mitigation or suppression policy in place. We would have this very large peak here, unfortunately, of mortality within the spring, summer months. And so that's without any type of regulation. So if we look here at this results, this is going to be with the mitigation strategies. And so what we need to look at here, again, if we look at the x-axis, we can see time, as we talked about before, and months. The y-axis, we're looking at critical care beds occupied per 100,000 of population. So think about the hospital setting. Think about beds being designated for patients who are in critical care. And so that's what we're talking about on the y-axis here. What I want you to take a look at is this red horizontal line across the very bottom here. This red horizontal line is the surge critical care bed capacity. So that's going to be those numbers of critical care beds designated in a hospital or within the healthcare system to be able to give adequate care to people who need it when they come to the hospital. So that's an important line to orientate yourself to. Additionally, this blue line here or this blue shaded area, this is going to be the time frame that would include these mitigation strategies, and we'll look at them individually. So approximately April to July 2020. Okay, so what you need to do here to look at this, this graph is to first start with the black one. That would be if nothing was done. Okay, so you can see here the very large surge in critical care beds per 100,000. And then we get a little bit more stringent. So you can see what the different results would be for each of these in isolation. So the green one is going to be just closing schools and universities. The orangish color here would be case isolation. Then we get a little bit higher into a combination where we have case isolation and household quarantine. And then the blue line is going to be where we're including all of that. So case isolation, home quarantine, and social distancing of those older than 70 years old. So obviously the ideal here would be this blue line where we see that we do have some type of reduction in the critical care bed outcome per 100,000, but we're still going over that red capacity line, which we can see at the bottom of the horizontal aspect of the graph here. Laura, anything else you want to add to that one? Oh, you're muted.
Thank you. Yeah, so the only thing that I would add is because of what you just pointed out, where the blue line, even though that's the best, it's still way above what our ICU capacity is. So what the authors concluded is that this idea of doing mitigation, that this is insufficient. Like this is not good enough because of that big gap.
Right. And another reason why it's important to kind of put that in comparison, if we were highly exceeding our critical care capacity in the hospitals, even if more people were showing up with COVID-19, that means obviously they wouldn't have access to those beds, but it also means people who just are going to the hospitals for normal critical care issues, car wrecks, heart attacks, those beds would not be available and those services would not be available, which is, I think, something that we don't normally necessarily think about when we're looking at things within this context associated with coronavirus.
Yep.
Okay, so we're going to look at the other option that was looked at in the model, and that's going to be the suppression strategy. And so remember, that's going to be a more stringent, more intensive type of approach with some stronger restrictions. So these two graphs are the same graphs, but the top one is zoomed out and the bottom one is going to be zoomed in. So we're going to look at the top graph first. So again, we'll orient ourselves to the X and Y axis. We can see that the x-axis here is going to be time. And then we have the y-axis, which again is critical care beds occupied per 100,000. We have that red line going across again to help us note the surge critical care bed capacity. And then again, we have the shaded blue area, which would be the time frame for the potential measures. So, the different types of implementations of policy regulation. So again, we have the black do nothing line where we can see that we very harshly are going to overload the system, have a lot of people who need critical care. And then we look at the different options of a more suppressive type of approach where we have multiple types of measures in place. So if we look at the orange line, that's going to be where we have case isolation. We also have household quarantine and general social distancing. And then if we look at the green line here, this is going to be encompassing all of that, but also school and university closures, case isolation, and general social distancing. So if you look at those two lines, in particular the green one, you can see that for this shaded blue area, it's staying below the surge critical care capacity line for the most part, which is positive. But then you say, well, wait a second, why is there a surge in the later winter months? And unfortunately, that is one of the outcomes associated with this model that they did note with the suppression strategy. There is the potential for this basically outbreak in the winter months later on. Now, if you looked at the bottom, the zoomed in graph of this top one, what we really want to note at the bottom here is we want to note in relationship to that critical care bed capacity red line, what do those different measures look like for the suppression model? And so you can see that within this blue shaded area, particularly the green one, we're staying below that critical care bed capacity, which is going to be super helpful for the healthcare system. Laura, do you want to speak to the winter months response at all for this particular graph?
Yeah, I mean, so I guess I think we'll talk to that more in a couple of slides. So let's just hang on to that point. I mean, but I do want to make sure you guys just sort of digest that, right? So what this is saying is if we did all these things very aggressively for 5 months and then we lifted that in September, we're still going to pretty much have some substantial peaks. Okay, so this should be disturbing to you,
right?
But we're going to talk more about this.
Right. So out of the two, though, acutely, the authors came to the assumption that the suppression model would help buy time in trying to put together a more appropriate response and not overload the healthcare system.
Yeah, which is, of course, very important. Mm-hmm. Okay, so that kind of sums up the results for that model itself. But remember when we set this up, we said that all models have assumptions and they're only as the data coming out is only as good as the data going in, right? And there are a lot of unknowns here and we have to acknowledge that. So I'm just reiterating part of the transcript from the statement from Dr. Birx from one of the press conferences, where she says that all modelers have their favorite inputs, they have their favorite integrative functions. So we as the US are trying to evaluate those and create the best model for the US. Now, that being said, since this came out, what is it, probably almost 10 days ago now, or just right at 10 days ago, I haven't seen anything come out from the US in terms of a better model. It's not to say that there's not one that they're working with, but they haven't put one out in the public domain. So with any modeling that is done, modelers always test their assumptions. So, you know, we mentioned earlier that they used an R value of 2.4, but they test variations in that ranging from 2.0 to 2.6. When we do that, we call that a sensitivity analysis. So we try to figure out which assumptions were the most important for how they influence the model. And that's what we're doing in these sensitivity analyses. So the authors of this Imperial College model tested that range of R values, and they also tested the severity of the virus. You know, so there were some assumptions that they made on the percentage of cases that would require an ICU bed. So those were big assumptions that they made, and they wanted to see what was the impact of varying those assumptions. And when they tested that range of assumption, or those ranges of assumptions, they found that suppression strategies still worked the best. So the model held up to the variations in those assumptions. I want you to, you can do this now or you can do this later, but there's another model here that I'm just going to click to, and I'll tell you in a minute where this model came from. Let's see, I'm going to have to change my app to share this. Let's see. Okay, there. Are you seeing that? Can I get a, yeah, Susie's giving me a yes. Okay, I'll talk in a minute about kind of where this particular model came from, but I just wanted to show this to you so that you could kind of visualize what a model like this looks like. So this is not the Imperial College model. It's not publicly, they don't have that publicly available, but this is a different, similar model. And why I wanted to show this to you was you can see down here we have the different inputs, and in this software program you can vary those inputs and you can see how it changes the results of the model. So I just want to show you how it kind of moves, so you can see if I change the size of the population, how the results of the model move, which that's basically what we're doing when we're talking about this sensitivity analysis, where we're testing a range of assumptions. So this is just something I kind of want to show you, something cool if you want to kind of play with it and understand a little bit more about how these models work. Okay, so those are some of the kind of limitations, basically, or underlying assumptions of the model. So what did the authors conclude? Well, in summary, they included that you have to layer interventions. You know, we went through that list of non-pharmaceutical interventions. You can't just do one, you had to do more. And when you did the combination of interventions, that was the most effective. They also concluded that suppression is a better goal than mitigation, because when we just tried to mitigate, we couldn't get down to the ICU demand that we needed. So this kind of outlines for suppression what the most effective combination was, and it was basically all the possible interventions for 5 months could get the R down to below a value of 1. But that these policies would basically need to be maintained until there's a vaccine available. Otherwise, when you lift them, you're going to have that peak. Now, if you only tried to do mitigation, which again, they recommended against, then you could reduce the epidemic by half. So remember, Susie showed us that by doing nothing, we'd have 2.2 million deaths. So then we'd only have 1.1 million deaths if we just did mitigation. And we'd also reduce the peak healthcare demands, because we would flatten that curve. And so we would reduce peak healthcare demands by 2/3. So just to be frank, these are two really bad choices. So neither one of these are good outcomes. The suppression goal is not a great outcome, because we have to do it for at least 5 months. And then if we do it, we still have a peak after that. So the policymakers that have to look at these two things and make a choice between doing these two things, they're in a really hard place. And then the other thing I want to point out is the statement that I have here is a quote from the authors at the bottom. And it says, "We do not consider the ethical or economic implications of either strategy here, except to note that there is no easy policy decision to be made." Okay, so what I just want to iterate that point. So what we're talking about today is we're talking purely from an epidemiologic spread of disease public health perspective. There are ethical aspects to this as well, and there are economic aspects to this as well. And frankly, the economic aspects overlay into the health aspects. And in a press conference earlier this week, our president talked about concerns about economics and how those can translate into death by suicide. And I think that that's absolutely a real concern with the economic situation that we're in. So we are really looking at this through one lens, but Susie and I wanted to make sure that we, brought up the point that there are other lenses through which this has to be looked at to make these types of policy decisions.
I think that's a great point, and I think everybody's probably still processing this individually and with your families, and you may be seeing these different types of stressors for yourself in regards, I know we certainly are within our family, the implications that are associated with trying to suppress or mitigate the current effects of COVID-19 and how that's affecting our families economically and just emotionally. So there are many, many things that the policymakers have to take into consideration when they make the recommendations that they do.
Yep, absolutely. So as I said, if you were just trying to use the results of this model from a health perspective and kind of make a decision on which interventions you were going to do, you're kind of stuck with two bad choices, right? Or what feels like two bad choices. But there's been some other commentaries that were published or have been put out there around this model that may give us some hope. And so I wanted to kind of share some of those points with you. They're largely based on this the output from this one individual, Tomas Peyo. And I kind of tee this up as proceed with caution, right? So one thing that's really important in the situation that we're in today is that where do we get our information? Is it a reliable source? So the data that Susie and I have talked you through up until this point comes from the Imperial College of London. It comes from well-respected epidemiologists who are experts in their field. That study was not published in a peer-reviewed paper, which would be our ideal scenario, but frankly, in the time that we are in right now with COVID, we don't have the time to wait for authors to submit papers to journals and go through peer review and wait to be published. So for that reason, it's okay that it hasn't been peer-reviewed in a publication like that. Now, in contrast to that, so this individual, Tomas Peyo, who I mentioned, I have his credentials listed here, and you will see that he doesn't have a medical degree, he doesn't have a public health or an epidemiology degree, but he is certainly an accomplished individual. He wrote all of this critique up and published it on the source called medium.com. I wasn't familiar with this until I came across this. Medium.com advertises that they don't fact check their articles. So like I'm saying, proceed with caution, but I think that he does raise some really good points. He also, to kind of, I guess, lend some credibility to his work, he does provide on this site a list of people who are experts in this field who have purported to support his work and endorse his articles. So I just wanted to kind of lay that out for you. But one of the first points that he makes is that the imperial model really doesn't consider the value of time. And I really just think this quote that he has in his article explains this the best. And he says, "What if you were about to face your worst enemy of which you knew very little and you had two options? Either you run towards it or you escape to buy yourself a bit of time to prepare. Which would you choose?" Okay. So the model itself doesn't incorporate this value of time. So I'm going to go back and kind of show you, if it did, what it would look like. So the reason we know the model doesn't incorporate the value of time, it's because these ICU beds stay flat over time, okay? But the idea would be is during this blue period, as we're preventing the peak, or we're not preventing, but delaying the peak, that we are building up our capacity, okay? So this delta between the peak of this curve and the ICU bed capacity would be smaller, okay? So we'd have more beds. So this model doesn't really incorporate that. So there absolutely is a lot of value in buying time, in making sure that we have enough personal protective equipment for our healthcare workers, ICU beds, ventilators. As Susie pointed out earlier, not only are we decreasing the cases of COVID, but we're also making sure that we can care for patients that have other needs. So I think that's a little bit of hope that we can consider in the model that wasn't actually described. So here's the second major point that Tomas makes, and that is that the Imperial College model doesn't really consider the most severe non-pharmaceutical interventions. And I'm just kind of calling that lockdown, okay? So it does talk about social distancing of the whole population, but it's not truly the very aggressive lockdown that you're seeing in some other countries. So for example, in Wuhan, which of course we all know is sort of the epicenter of where this virus started, or where the first epidemic was, they were very aggressive ultimately in their lockdown. They only let one member of a household leave the house, and at a cadence of every 3 days. You know, you're not seeing that anywhere here in the United States, not nearly that aggressive. But just look what happened here with the data from the time they had lockdown. Then you're still going to have quite a few cases, right? Because people have already been infected, and then they're starting to, it's starting to present itself, and they're becoming symptomatic. But then over here, in a very short period of time, the disease is completely under control. And out here, as of last week, they were having 1 to 0 cases diagnosed in this area. And this area is populated with 60 million people. So between 123 and 33, they got the infection completely under control because of these very aggressive lockdown measures. So, to go back to, we were looking at 2 kind of bad options, and part of the fact that one was a bad option was because it was 5 months. Man, it's like, oh, we're gonna have to go through 5 months of suppression. Well, perhaps what he's pointing out here is if you're more aggressive, you can get it under control faster, okay? So this is the second point that he makes. And there's in this website, and then we have the link to this website here. You're welcome to look at this. He's got other countries too that have taken these measures, and you can see different graphs. This one just kind of showed itself the best. So. Okay, so this is what we're going to wrap up our comments with, and then we'll have some time for questions. But this is from that same source, from Tomas Peyo, and he calls this chart a work in progress, and so I'll repeat that and just kind of share that with you. But what he was trying to do here was sort of outline the different non-pharmaceutical interventions. So you can see this list is a lot longer than what we saw in the Imperial model. So there's definitely more interventions than the one model looked at, and then he's kind of mapping that out versus the countries and what each country has done. And then what is the impact of these interventions? So they tried to organize these from what are cheap interventions to what are expensive interventions. And when we talk about expensive interventions, it's kind of it's from the aspect of society, right? So when you close, this is all closure. When you close these things, or when you have travel bans, this is a economic cost to society. And so at a very high level, the point that they're trying to make is that these countries that early were aggressive on detection and isolation, they were able to avoid doing these closures later on, okay? Whereas the countries that have failed to do that early detection and isolation they were forced to pay, to use his words, they were forced to pay with these closures later on. So I know that still kind of sounds doom and gloom, but when you look at those 2 prior options that we looked at, I think that there's some other ways that we can tweak these interventions that we might be able to result in some better outcomes. So that's it in terms of our data. I'll take the responsibility for this slide. I don't want to throw Susie under the bus, but this is my recommendation to you guys. If you don't take anything else away from this, please know that it's very important to socially distance yourself. If you don't know what this acronym means, you can look it up. I'm not going to say it out loud. But that kind of wraps up our conversation, what we had for you guys today, and we'd be just happy to have a chat and take any questions that you guys have.
I would also like to note, I just posted in the chat the Google form, the Google feedback form link. If you guys could please fill that out so that you can get the appropriate notation for attendance today. We would greatly appreciate that. We want to make sure that you do get your attendance for attending the Lyceum. So we'd like to open it up for questions that you may have. We'll try to address them the best that we can. If we can't, we'll just let you know. But again, we thank you for your attention.
Yeah, I did just get oh, can I reshare the PowerPoint? Yeah, I'll upload that PowerPoint again for y'all.
So any questions at all about the models? I think one of the largest takeaway points is putting some stricter policies in place and regulations right now hopefully can buy us time to bulk up and to strengthen our healthcare system, our critical bed capacity, support for our healthcare providers, and obviously potentially a vaccine and other types of pharmaceutical interventions to decrease the outcomes associated with COVID-19. All right, I don't think we're getting any questions. Laura, do you want to send anything else? Can you resend the link to get credit? Sure. There should be the link.
Yeah, someone sent me a private message and said, is there any chance we could see a vaccine by August? You know, so a typical timeline to investigate and release and approve and release a new vaccine is 12 to 18 months. Although I think that what we're seeing is the healthcare system is doing things in record time that we've never done before. So I think it certainly could be shorter than that. But it does take a while to do these trials to make sure that it works. I see someone has a question about chloroquine. Catherine, you're welcome to verbalize that if you want to take yourself off mute or type it in the chat box. So hydroxychloroquine is an anti-malaria drug. You guys may have seen this on the news that it's being tested to see if it works for COVID. So there were some anecdotal reports that it had an impact. And so now they're using it in the clinical trial space. It got a lot of media attention very quickly. Unfortunately, there wasn't enough research to support it. And so there have been a lot of prescriptions that have been written for it. So some people are using it experimentally. Some states are really cracking down on that. You know, there's a lot of pros and cons to that. So, you know, if we don't know yet if it's going to work, then what you can result in is shortages for people that are using it for different conditions. So there's it's not just used to prevent malaria, it's also used for a range of autoimmune diseases like lupus and rheumatoid arthritis. So there's been reports in some areas where people can't get it for those conditions who have been stable on it for a long time. So that's one of the concerns. And then, you know, just another concern is using it when we don't have research to show it works. So different states are taking different approaches to whether or not they're letting doctors write prescriptions for that and pharmacies fill them. Catherine, I don't know if that answers your question. Okay. Yeah, so you have a question about the combination of azithromycin and QT prolongation. I'm sorry, the combination of azithromycin and hydroxychloroquine. You know, I am seeing that it's that they're being used together also. I don't know if, Susie, you can comment on that. I can't comment on that combination specifically around the QT prolongation.
I don't know specifics on that. I'd have to look it up in regards to, you know, how they interact with each other. So no, I can't comment specifically. I do know that there's a great concern just in regards to resources across the table here, in particular with chloroquine. You know, as Dr. Happy mentioned, people need that medication for ongoing chronic diseases, and we're seeing that, you know, different types of pharmacists and physicians and providers are prescribing it for people because of the desire for it, because of the media regarding its effects on COVID-19, and they're having issues getting access to that medication that they normally take. So I think one of the biggest takeaways is just being mindful of our resources and what we need and what we don't need, so that we can try and make sure there's enough to go around for everybody.
So do we want to close out with a one-word check-in? I'd like to see if our emotions have changed, or just kind of what your thoughts are. Some of the students are asking about the getting credit for attending.
If you could fill out the Google Forms, that will help with attendance.
Yeah, and I think that's specifically for the students that are taking this for Lyceum credit.
Mm-hmm.
So maybe those of you, I think Catherine's in our pharmacy program who asked the question. So maybe those of you who are in a different program like that, it would be irrelevant.
I can speak to that. This is Carrie Hefferly, Dean of General Education. So yes, they're getting Lyceum credit for this. Undergraduates are getting Lyceum credit for this. And yes, it is being posted onto their WooSync paths. So if you've already attended any, they should already be up there. And this one will be posted to your WooSync Lyceum count within the next day or two. Thanks.
Thank you.
Thanks, Carrie.
This is such a great opportunity for us to get to interact with undergraduate students and other students that we don't normally interact with on a normal basis in our program. So we're just very appreciative of the opportunity to share with you some of our thoughts in regards to the information that's out there.
Yeah, and yeah, I second that. And I think Susie and I would also just take this opportunity to say, you know, we're both in the health profession, and you know, this is such a hard time. And so we just want to encourage you guys to really practice self-care, and that we're both really focused on that for ourselves, our friends, our families. Try to get outside, try to move, try to get some exercise, you know, interact with your colleagues and friends over, you know, medias like this where you can see each other, and just, you know, try to stay healthy and stay positive. And we'll be thinking about you guys all.
Yeah, especially for you seniors. I know this is probably not how you wanted to end your senior year of college, but just know that we are thinking of you, and you will be able to say that, you know, you graduated during this pandemic, which for better or worse, but we certainly are thinking of you all.
Yep. And don't hesitate to reach out with any questions, guys.
Yes.
Take care. Guess we'll sign
Bye-bye.
off. All right,
Thank you.
Thank you guys. You did an awesome job.
Thank you.
Carrie.